Hi everyone, welcome to Third Spacing the podcast, where we explore important issues on the peripheries of clinical medicine in Singapore. This is your editor, Hosan. In this two-part episode, we commemorate the life of Prof. Cynthia Goh, who passed away due to pancreatic cancer on February 13th, 2022. In the previous part, Prof. Cynthia talked about what palliative care entails and shared about her journey of establishing hospice care in Singapore. In this part, Prof. Cynthia discusses some of the most important issues in palliative care, including patient dignity, advanced care planning, and euthanasia.
I feel like we use the term to live with dignity, to live with our disease with dignity a lot. I'm not really sure what it really means, right, to live with dignity. How do we begin to approach this question?
Yeah. I don't like the term living with dignity, because dignity means such different things to different people. To some people, dignity means that, I have to look nice and respected, or the people around me treat me with respect. That's dignity for me. But for other people, dignity means I need to be able to go to the toilet myself. I need to be able to dress myself. I need to go on holiday. And when you look at a patient, and we always teach this in palliative care, the person sitting in front of you in hospital pajamas is totally devoid of personality. He could be any patient. But behind that person, you have a bank manager, you have a remisier, you have a Karanguni man, you have all sorts of different people in the same pajamas. So how do you look at them with different sets of eyes? Because dignity for these people are going to be very, very different. For people who are used to being homeless, sleeping on the street, dignity means the ability to be able to sleep on the street when I want to. Of course, I'll go indoors when I'm cold and wet and all this sort of thing. But the rest of the time, I want to be able to live the kind of life I want to live. I want to live on a void deck. So, in Singapore, we have no homeless people, in inverted commas. Of course we have homeless people, and they hide, right? They go to the beach, they go to all sorts of places, but they're actually homeless, but they find their own homes, if you like. For example, when we do home care, I remember looking after one of my patients who lives in the void deck, and he made himself very comfortable in one of these cozy corner places in the void deck. He had his own space. It was near the public toilets. He could have his shower and wash whenever he wants to. He could chat with all the elderlies who come and visit that cozy corner. That was his home. Where else can we move him? If I ask myself, if I move him into a hospice, he'll be miserable there. He'll be playing hooky all the time. We can't keep him in there. I mean, hospice is not prison. People can walk out anytime, and he will walk out. These are not people you can confine within four walls. But for him, the dignity is having his own space on the void deck. And we try to make that relatively safe and comfortable, and legal, whenever we can. We talk about the right of patients to know or not to know what is happening to them. Because in a way, if you don't understand your medical condition or how long you have to live, how are you going to make good decisions about how you're going to spend your time? On the one hand, people used to accuse people in the hospice movement of, they always tell the patient the diagnosis, so don't go to them because we don't want mother to know she has cancer. And these people will tell her. So we used to get bad reputation. And these are some of the barriers to accepting palliative care, because this is a myth. We don't force information on people. But there are people who genuinely want to know, but whose families are not prepared for them to know. So what do you do in a situation like that? Well, what you do is you don't force your way through. You don't alienate the family and say, the patient has a right to know. On the other hand, you don't, lie to the patient for the duration just to please the family. So there are skills as to how we can negotiate this. And also learning whether the patient genuinely wants to know or not want to know, and whether the family is right in protecting the patient, or is the family actually protecting themselves from, having to live with a patient who knows that he's going to die. I can't cope with this. I can't cope with the thought of my mother dying. And if my mother knows that she's dying, I can't cope with that even more. So I don't want her to know. Why does she need to know? I make all the decisions. I pay for all the treatment. So negotiating this is, well, in a way, our bread and butter in palliative care. It's things that we deal with all the time. And people have different ways of dealing it. And I'm sure there's a different solution for every individual situation.
Then how would you approach a patient who doesn't want to know? Because I guess in a way, if the patient does want to know, it makes it a little bit easier in the sense that you just have to negotiate the family, right?
Well, you have to read carefully whether it's true that the patient doesn't want to know. Okay. Actually, it's not that difficult. For example, you can say to the patient, you've got your medical condition, which is quite serious. I don't know how much you want to know about this. Would you want me to tell you some more? The patient could easily change the subject. Oh no, you just tell my family. But of course, they can also change their mind. Sometimes you go a little bit nearer to say, your condition is quite serious, and they ask an irrelevant question. Okay, you'd better pick that clue up, because that is the cue to say, don't go any further. I'm not ready for this yet. Let's talk about something else. And if you then go back to the subject again and again, it's actually an assault on the patient's, preference not to know, or not to know at this stage. The patient may be later able to process this and want to know a bit more information. But today, at this interview, you must not go back and keep on pressing the question. And this is some of the things that we do wrong in many of the things that we do. For example, advanced care planning is one of the things that the government is very keen on, that we should plan how we want to spend our last days. And they basically want every elderly person to have an advanced care plan, which is fine for some people who do want one. But there are also people who don't want an advanced care plan, or is not prepared to think about it, or not yet, and not at this stage. And yet the way we go about it is that we have a checklist. Okay, everybody who's enrolled into a certain program for the elderly, for hospice or whatever, ACP must be done, advanced care plan, ACP. And there's a form, and you have to tick, have you done this, have you asked that, have you asked that? And we have ACP coordinators who are trained to do this. Now, I have no problems with the training and the ACP coordinators. The only thing is how we measure outcomes. And the measure outcomes is to tick every box, ACP done. Okay, but if the patient's not ready to discuss ACP, you cannot tick that box and say that ACP is done, and therefore you failed and you haven't completed your KPI. Okay, so this is where things go wrong, and places where we need to improve the system.
So I guess in the term of like ACT, they try to institutionalize it because they realize that it is quite important for a more holistic care in a way. But at the same time, the application of it is definitely against what it in itself is trying to gain. So how do we begin to unpack and approach like this struggle between efficiency and a more personalized, human-centered care?
I think first we need to be aware that there is this tension, and that the situation is not black and white. I think we should still try to systematize the way we approach problems, but also to be wise enough to know that ticking the boxes is not the real KPI. The real KPI is having attempted to talk about it. It's not that I have completed the ACP, therefore I've done this at KPI. It's, have I explored this? And is the patient ready? Now, the other thing we know about ACP, advanced care planning, is that people change their minds. And people change their minds constantly, either way. People who say, I never want to be on a machine, breathing machine, if, my lungs give up. When their lungs actually give up, they say, well, let's have a go. We'll have a limited trial. Nothing wrong with that. In fact, that is what we would recommend. See whether it works, or see how I can tolerate it. If life becomes intolerable when I'm on this machine, I want to be able to say stop. Not a once for all, yes, I want, no, I don't want. So all that takes thinking, and it takes good training, quite labor intensive really, to get people to understand these kinds of concepts. But I think that's how we have to do it. I don't think there's an alternative to say, this is black and this is white, because when you're dealing with these kinds of life and death decisions, there is no black and white, and there is no right or wrong. You can't say this patient, because he's old, shouldn't go on a ventilator. This patient, because he's young, he needs to have dialysis. And if he decides not to have it, then he's committing suicide. Okay, which is how families and doctors and nurses view it. If you're given a choice of life-saving treatment and you refuse it, patients under a lot of guilt if they don't want it, if they genuinely don't want it. Because the family would say, how can you bear to leave us? You're going to die if you don't have this treatment. And how many patients do we know who are having treatment they don't really want, but they want it because the family pressures them to do it? And families think, life is everything. So if I can blackmail my father into getting treatment so that he lives a bit longer, it's okay. It's okay. It's for his own good. Never mind what he thinks. Doesn't matter. And for us in Asia, harmony within the family is a very, very important thing. None of us want to go against family wishes. So if you're one, which is a patient, and you have the whole family, which is your community, then if you want to preserve the peace, sometimes it's better to just go along with whatever everybody else wants. And for us as practitioners, for doctors, for example, our first duty of care is to the patient. Our second duty of care is to the family. So the patient always comes first. So you say, what does the patient want? Well, the patient says, I want what the family wants. On the surface of it, that's fine. Once the patient delegates authority or decision-making power to the family, that's fine. Ethically, nothing wrong with it. But the question is, does he really? And how much pressure is he under to make a decision like that? So when you see the reality, it's quite different. The next question is, does palliative care include a service of killing patients off, which is euthanasia? Euthanasia is the deliberate shortening of a patient's life, usually for what is considered merciful reasons. We're talking about voluntary euthanasia, say at the patient's request, or sometimes at the relative's request, which isn't voluntary, right? So we have grappled with this problem, and in the Asia Pacific Hospice Palliative Care Network, we've come down very strongly on the side that palliative medicine really has no role to play in euthanasia because of the very values that we stand for. Because if we say that we value every moment of life, and this is key to our philosophy, key to the palliative care philosophy, so how would we want to shorten the moments of life? It's incompatible. Because every moment of life is valuable. Not everybody agrees with this. Okay, and in particular, in the euthanasia debate, people argue that there is a point in time when life is not worth living, and I don't want to know about it. So the question is, should palliative care embrace this part of people wanting to die? Now, I must emphasize that the people who want to die, who want euthanasia, is a very small group who find life intolerable. They exist, but it's a very, very small minority. The majority is that people can imagine a time when life becomes intolerable, but they want to live until the very limit until they find it intolerable. And this is where the palliative care comes in, that we help make life tolerable for as long as it takes, right? But the question is, do we take part in the killing? The group of people that I work with in the palliative care community, we feel very strongly that palliative care has no role in shortening patients' lives. Just as if society feels that we need executioners for our prisoners if we have the death penalty, then you train executioners who do this specific job. right? So if euthanasia ever becomes legal in Singapore, then you train a group of people who is able to administer it, and they don't have to be palliative care physicians. We actually feel very strongly that we give the wrong message to patients who are receiving palliative care, because if the patients don't know that the medicine you're giving them is to prolong their life or to shorten their life, it becomes very difficult. So am I taking this morphine to kill me, which many people believe, or am I taking it for my pain? But if you can say categorically, we will not do anything that's likely to shorten your life, please take this medicine because it will make your life much better. And it's not meant to kill you. If we can speak this with conviction, then it makes the practice of palliative medicine so much easier. And it's not just the patient, it's the relatives as well. They will suspect, do I really want to bring my father to see this doctor? They might knock them off, with or without our consent. So it makes life extremely complex for anybody providing palliative care. If, we say, sometimes we give medicines to prolong patients' life, and we know that palliative medicine with people living with good symptom control do live longer than those who don't receive palliative care. And there's growing evidence that you actually survive longer under palliative care than not. But if you then bring in the equation where they can kill you off as well, then it really makes life far too complex. So I think we have to make very clear that in palliative care, we don't shorten patients' life. We are not providers of euthanasia. We should never be.
Beyond being a provider, do you feel that you have a role to, facilitate a discussion about euthanasia and physician-assisted suicide?
There's very little difference between physician-assisted suicide and euthanasia. It just depends on who pulls the trigger. And I would put it all in the same category. I'm always very troubled by the dilemma that if you take part in physician-assisted suicide and the patient botches the attempt, okay, you give them the medicine, they don't take all of it. What do you do then? Do you kill them off or do you resuscitate them? I mean, it's an unnecessary dilemma to put yourself in, right? It has, lots and lots of things that you really don't want to know. And so, the whole debate of, who pulls the trigger really is irrelevant. We believe that doctors shouldn't be involved in this. But then there are doctors who disagree, and society may disagree. I hope society doesn't. And I hope that there are enough people in our community, and I'm very encouraged that all our major religions are against euthanasia. So there are enough people in our community to say, this is really a very dangerous road to go down. And we do worry about the vulnerable, people who are physically or mentally disabled, who have little say in whether they should or shouldn't be put down. So, it's a whole societal debate, but lots of ramifications. But I think it's important for us to know where we stand in that debate. I wouldn't say your earlier question about would I facilitate a debate on euthanasia, I probably wouldn't. It's a real Pandora's box. But I think that as and when the euthanasia debate erupts, as it tends to do from time to time, then we should know what our position is. And we should be able to enunciate that position.